Hello, everybody, and welcome to this session of ISPO. My name is Paul Charlton. I'm an orthotist, and I'm delighted to have with me today Edine Steed, who is a physiotherapist and a close colleague of mine. We work together at Northwick Park. And between us, we're going to be talking about the holistic rehabilitation planning and strategies for orthotists, but really with it being holistic, we're going to try and cover the other professions that are involved that we should be talking with and who would be looking to participate in the care of the patient. So first slide, please, Adine.
There we go.
Thank you. So really the thing we've got to think about is where rehabilitation fits. And obviously if somebody's had a stroke, there's a risk, potentially a risk to life. And the first thing that's got to happen is they've got to be made medically stable. So it may well be that they've been admitted as an emergency, and obviously getting things stabilized to preserve life is the first priority. But once that's done, hopefully successfully and minimizing any damage, then the patient can start to be on the road to recovery, and we can think about rehabilitation and then the long-term management and what the implications are.
Yeah, and I think it's about thinking about it being a journey, isn't it, Paul? It's not a linear journey. It's not a straight road that our patients go on. It ebbs and it flows a bit like a river. I think it's a good analogy. It twists and turns and meets obstacles along the way. There's downhill rapids. There's smooth kind of plains. So it's worth just bearing that in mind for the patient, that they're not on a straightforward linear journey. It does flow in different directions for different people.
Yeah.
And I suppose we were thinking, weren't we, Paul, about when does rehabilitation start? And it's really about from kind of day one, really thinking about promoting independence and early mobilization, and thinking about our 24-hour routine, really, with by all staff and all carers and family being involved from day one, and trying to think about early alignment issues and prevention of contracture, and particularly around from a kind of upper limb and lower limb perspective, early weight bearing, early normal movement, and progression as the patient is able. And particularly with the upper limb, we're often quite concerned about the shoulder, aren't we, in terms of protecting that shoulder, particularly if it's a very weak shoulder. So again, thinking about different modalities that we may use to support that. So thinking around shoulder slings or tray tables on wheelchairs, or pillow supports when they're sitting in a chair, or pillow supports in bed, and just really trying to minimize the secondary complications of weakness and immobility, and try and really start promoting the fuller picture of 24-hour care.
And I think this is really useful for orthotists to understand. I think often as orthotists generally around the world, there aren't a lot of us around, and we're working across all pathologies and all fields, and we get called in at various stages. But I think there's potential for either us personally as orthotists, or even just advising on services, is how we can contribute to that very early care, and from day one, really. There is a role for orthoses to help with all of these issues that we're talking about, albeit that we may not all be involved in seeing them this early. I think it would be great if orthotists could integrate themselves more into the early stage and share our knowledge with the rest of the team.
Absolutely, and particularly around some of the key joints, isn't it? Like upper limb, shoulder protection in terms of bracing and slings, but also that kind of resting splints for ankles, and thinking about early use of ankle foot orthoses as well, in terms of supporting that early mobilization. A lot of the new evidence coming out is really advocating that in terms of supporting early standing with the best possible alignment. So again, not being afraid to get involved and intervene with devices from day one, really.
That's great.
And then Paul and I were thinking about, well, what is it that we're actually trying to do? What's the aim of rehabilitation? And obviously we're trying to think about maximizing and optimizing recovery and trying to facilitate best function. We're obviously optimizing things to try and return to normal. Obviously for a lot of strokes, particularly catastrophic strokes, there is no such thing as the old normal after the stroke, but it's just trying to implement normal normal principles of movement and normal ways of functioning and normal biomechanics as much as we can, and obviously using this to try and work towards improvement. Yeah, we're not trying to keep people as they are. We're trying to help optimize their recovery and optimize their neuroplasticity. And we're doing that really with goal-orientated rehab, so targeted interventions for particular goals and hopefully what the patient wants to work on. So standing, stepping, toileting, getting from their bed to the front door. So it's really it's patient driven rather than a therapist or orthotist driven.
What I'm always conscious of, Idine, is that personally, I see a real differentiation between rehabilitation and long-term management. So I think we've all got the potential to get better. Even if you haven't had a stroke, if you want to improve your balance, you can do things to improve your balance, and you can get better at sports, and we can all get better. But following a stroke, I think there comes a point where they probably reach a plateau of where you're going to be, and then they're left with some deficits that we need to manage long term. And I see that as a slightly different way of almost treating them, from aggressively trying to make them better and maybe challenging their balance and their normal to push them further, to then accepting, okay, this might be as good as we're going to be, and where we're got to get on with life. In which case, it may be a slightly different prescription from an orthotic perspective for that.
Yes, exactly. And it comes back to, doesn't it, of trying to find that where are we pitching things, isn't it, and where's that goal, what's that target we're trying to work on, and coming at it in multiple ways to try and achieve it.
Yeah, that's great.
All right. I suppose then from an orthotic perspective, Paul, do you want to?
Yeah, I think
lead on this bit.
Yeah, so there's some real specific areas where, from an orthotic perspective, we've got a big role to play. So managing range and preventing contractures, I think, is a massive one. As soon as there's any motor disturbance, there's potential for muscle imbalance, and as soon as there's a muscle imbalance, there's potential for contracture, which I think we probably agree is one of the most limiting things of rehabilitation. If you have got a big muscle imbalance, then that's where things get tricky. Then protecting joints and soft structures. We've talked about the shoulder, which is a pretty obvious one and a common one. But right throughout, and probably the next biggest one is the knee. If somebody's getting this stability by locking back on the knee and potentially hyperextending the knee and stretching the posterior ligaments there, that's something that as orthotists we can be pretty good at realigning and helping that. And the big balance, I guess, in rehabilitation is the facilitating mobility and getting them walking, but keeping it safe as well. They need to be challenged for to progress. But the last thing in the world that they need is a fall and a fractured femur. So it's getting that balance right. And we need to be very conscious of that when we're contributing to the to gait re-education. But I do think we can really contribute to the actual treatment So we talked about stopping a knee from going into full extension to protect the joint, but as well as protecting the joint by realigning the joint relative to ground reaction force vector, we can then start putting more normal demands on the neuromuscular system. So going from an extended knee to a flexed knee immediately means that you've got to start using your quadriceps or your knee extensors and your hip extensors. And I suspect that's an area where a lot of physiotherapists don't quite understand how we can input on there. Sorry, Dean, I'm not
No,
aiming
no, I
at
agree.
you because we've worked together for a long time and you appreciate the principles, but I think there's a lot of physiotherapists who don't realise that the impact that we can have in helping with that, which then contributes to motor learning and neuroplasticity. Facilitating independence is a massive thing, and even if we can only get a patient to take 2 or 3 steps safely, 2 or 3 steps makes a massive difference on your dignity. If you can go to the loo, to the toilet by yourself, is a huge thing. And then, as we've already alluded to, there's then optimizing the rehabilitation period, and then looking to long-term management and making things making sure things are as good as they can be long term. Thank you. So the complementary interventions, as is with many orthotists in the UK, and I suspect across the world, we tend to dip into seeing our patients as our profession is required. But there's a list of other professions involved, which I'm going to let Dean go through, but I might chip in on the odd one when it's relative to orthotics. Thanks, Dean.
Yeah, absolutely. So yeah, as Paul said, it's not, around the patient there's a team, or there really ideally should be a team, because that's how we potentially achieve the best for our patients. And we all come at things with a different, from a professional perspective, all of us come with a different way of thinking or a different way of problem solving. And the various professions attract different, different types of personalities, don't they? And different kind of thinkers. And hopefully that's all to the benefit of our patients. So I suppose, again, just thinking from particularly my bread and butter in terms of physio. So obviously a physio looks at an individual assessment of muscle strength and range of movement, coordination, sensation, pain, for some lower level patients, at their kind of respiratory function level. And really what we will be doing is kind of doing a detailed analysis really of posture in various postural sets. So in bed, sitting, standing, and then how someone gets from A to B in terms of their transferability, their gait, and their balance. And, physios love detailed, specific tests. We like to time things. We like to measure things. We like to have standard measures that show, yes, your balance is impaired, or yes, your walking is slow. We like to give that concrete numbers and data to that. And then really what we will do is then try and think about long-term and short-term goals in order to achieve to achieve someone's fullest kind of physical capacity. And some of the kind of things that we would do was obviously strengthening programs, stretching programs. We would again look at this 24-hour positioning program. We would be involved in terms of thinking around contracture management and spasticity management. So getting involved with decision making regarding kind of medication changes or very kind of focal interventions such as things like botulinum toxin. We would be involved in the decision making on that and the reasoning within that. We might be thinking about stretching in the sense of a serial stretch, so splinting and casting. As well as using, equipment such as treadmill training or hydrotherapy in terms of, water-based exercise, and other adjuncts such as electrical stimulation. So really, we're trying to think about that, a good baseline assessment of your kind of biomechanics and trying to think about how all those different systems interplay in terms of strength, range of movement, and coordination, and then trying to maximize function on that. Within that, we'll also obviously, particularly with our patients following a neurological injury, we'll have a good appreciation of, the cognitive difficulties that somebody may be having. and a good appreciation of what that then means for their physical function. So just because someone's got, grade 5 out of 5 strength doesn't mean walk, walk independently somewhere, because actually they may need supervision from a distractibility perspective, or supervision because actually they can't orientate to where it is that they're going. And so we'll have a role as well within our multidisciplinary team of feeding into to the other disciplines, and trying to work out the best solutions forward for our patients. Coming on then to some of our colleagues in the occupational therapy team, they're going to be more interested in really the real life skills. Yeah. So in terms of thinking around both your physical skills of how you get from A to B, but then also how that then interlinks with the individual's thinking skills and planning skills, and thinking how does that fit within their daily routine. So things like getting washed and dressed, things like grooming, so doing their teeth, brushing their hair, organizing their day in order to get their various household tasks done, or elements of their job done, and trying to think about in the kind of hospital environment of simple things, and how that then feeds into kind of transitional skills in the actual real world. So thinking around navigating the community, so getting on and off public transport, organizing themselves in terms of money, and kind of looking at kind of workability, as well as things like provision of equipment that somebody might need. So thinking around things to help pick up objects from the floor, extendable items to help with getting washed and dressed a bit easier, or again adaptations within, say, the kitchen in order to make chopping up activities one-handed, and so forth. So really trying to again play to people's strengths in order to let them function to their best ability within their day-to-day lives. And here in the UK, physio and occupational therapy really work closely in particularly in stroke rehab, in terms of that crossover between kind of physical skills and cognitive skills, and really we would do a lot of joint working on common goal areas. So it might be that the goal is planning a meal and cooking it. We may well then work jointly with the OTs in terms of actually facilitating that individual to stand in the kitchen. We might be using a standing frame to allow them to stand up at the kitchen counter and participate in the activity to the best of their ability. So again, that close working is really important.
If I could just add to that briefly, I think where there might be a real opportunity with us as orthotists is potentially working with the occupational therapists as to how patients can actually put orthoses on.
Absolutely,
So
yeah.
design the best orthosis in the world, and they might perform fantastically on it, but if the whole side's affected and they've only got one hand, how they put it on and how they get the footwear on, or how it interacts with the dressing and all the rest of it, could be a real practical use where we can work together.
Absolutely, and that kind of joint goals, isn't it, in terms of in terms of, as you say, that one-handed technique as to how to do something, or and again, getting the advice from perhaps an occupational therapist in terms of when you're planning that device, or and thinking, trying to problem solve through something for somebody. Okay, then in terms of again, we're quite lucky in that a lot of our patients do get some sort of input from clinical psychology. So looking again at kind of those cognitive skills, again around memory, attention, problem solving, things like mood and behavior, and again helping people come to terms and adapt to their disability. And they again may work on things like strategies, memory aids, education regarding the injury, and may well help draw up some guidance in terms of helping the team. So again, thinking around step-by-step guides for the patient as to how to do something, working on kind of what we call maybe errorless learning to a task. So again, putting for example, putting an AFO on that each time we do it in the exact same way, again to try and help that patient learn how to do the task themselves. Thinking around actually if we think about the from a mood perspective, and kind of and then their adjustment to disability. Again, this is something we come across a lot jointly, Paul, isn't it, in terms of people actually accepting that they need a device to help them, and what that device looks like, and what that device may maybe perceived by others to be like. And we're certainly mindful of that, aren't we, in our clinics, in terms of thinking about the what color is it, and what does it look like, and to try and that also helps in terms of obviously building in the individual's compliance to the device that we might be suggesting.
Yeah, a massive part of the rehabilitation process, I think, is the patient's motivation. And if clinical psychology can sometimes help with moods and motivation, then getting the patient on board with their treatment for all aspects of the rehabilitation, as well as orthotics, has got to be a good thing.
Absolutely.
Thank you.
Okay. I suppose another discipline involved obviously is kind of speech and language therapy, and this is obviously their primary role really is to kind of assess and treat and give support with communication difficulties. And again, this is really important. This is where I think when we work jointly together, Paul, is that support and communication for somebody in terms of thinking around strategies of use of pictures to try and help someone guide through and help them express themselves, us using pictures and gesture to try and get our message to understood by them, although yes, speech and language therapy obviously will be quite heavily involved in that kind of formal sense, but it can be quite helpful to try and help support someone's communication, and again having an understanding as to what their communication needs are, and not underestimating the power of the non-verbal communication, just actually how much we can do by demonstrating, how much we can do through pictures, how much we can do through drawing and writing, and just using a kind of total, what speech and language therapists would call a total communication approach, and trying to just give patients time as well, isn't it, in terms of letting them have their voice heard in whichever means that is, and also we're currently in the world obviously of technology, again utilizing there's various apps that can help in terms of picture selection, and helping that individual try and get their message across, and really tell us then what the problem is.
Yeah, I think the important thing for us as all therapists, I guess, is it's very easy to make an assumption that if somebody has an expressive problem, so they can't speak, that you assume that they can't understand either, and it must be so frustrating for them if we're giving them pictures and saying things 3 times when they can actually understand all right, but the problem is they can't then express themselves, so it's just digging a little bit for to do things appropriately.
Yeah, or again that assumption, as you say, that they can't understand, and so we just talk to the relative or we talk to the carer, and we don't actually talk direct to the patient, isn't it? Yeah.
That's great, thanks.
Right, and then again, I suppose here in the UK, we would have obviously in terms of kind of social work again involved in kind of thinking about what someone's care needs are, thinking about what kind of support might be needed from housing or from a benefit perspective, and again thinking about support with accessing assisted transport here in the UK, so things like cheaper travel, things like we have obviously like blue badges, so people, if they're coming by car, can park closer to their destination, or they don't have car parking charges. These are the kind of problems that our society has in terms of enabling our patients and our clients to really access their world and access their community. So again, thinking about the coordination and additional support that might be available for people, not forgetting that.
Even if it's as simple as sorry, I put this one. I suggested this profession because again, we can, as orthotists, we can make a huge difference. But if they can't get the thing on, or they have difficulty in getting up 3 steps out the house, or to get out of the house or outdoors, could it be arranged for somebody to help them to do that part? And that's really what social services is, sort of facilitating the help of other people to help them be as good as they can be. Thank you.
Yeah, exactly. Okay, and then I suppose other services that again that we need to be mindful of are things like tissue viability, so from skin condition specialists, again continence advisors. So again, is going to have a big impact in terms of again quality of life and a skin breakdown. Thinking about relationship support. It's not just the person has had a stroke or a brain injury, the whole family has had it, and it's again the support around that that individual, and then not forgetting kind of dietitian, both for optimizing someone's well-being in terms of having the right level of nutrition and calories, or on the other end of the spectrum, actually ensuring that someone is managing their weight appropriately. It's not going to make walking easy if you're carrying some extra kilograms around. So again, just thinking about tapping into either the expertise of those professions, or if you're not, just being mindful of that and giving advice and education to your patients in clinic, really about saying, actually, if we could think about perhaps a bit of weight loss, this would make your walking much easier, much quicker. Or on the other extreme, if you've got somebody who's underweight, actually thinking actually from a pressure perspective, having a bit more weight would be helpful. You've less bony prominences and so forth. So again, just not forgetting that, really. We've got good we're in a good place, aren't we, in the clinic to give this ad hoc advice that just might change things for people.
That's great.
Have you got anything to say on that, extra to say on that, Paul?
I think there is relevance to orthotics in just about all of these, to be honest. And I appreciate that different parts of the world and different services will have access to different aspects of this service, and may not have access to all or even many of them. But I think bearing in mind that all these needs, regardless of which profession addresses them, could be taken into consideration to make things better for the patient. And the orthosis can be a really important part, but it can be made far more effective if everything else is complemented as well. Is this our last slide, Nadine?
I think yes, we're coming to just coming
Yeah.
to conclusion. Yeah.
So hopefully what we've done is given quite a holistic overview of the different services and the different impacts stroke has, other than the mobility ones that we tend to deal with more in orthotics. So hopefully we've made everybody aware of those services. But also to say many services are unaware of the contribution orthotic intervention may have. So I think a major part of our role as orthotists is to let other professions know what we can do, and hopefully people will access us and use our skills for the betterment of rehabilitation generally. Thank you very much.
Thank you.
Appreciate it. We hope to be around for questions and discussion now. Thanks.
Thanks.